Hello, this is Christopher South, and today we're going to be talking about better documentation. And I hope that you take away something from this presentation that'll help you in your own documentation at your own service, and will also help you just to improve your care and some things to look for. So, this is not a specific training for your agency. This training is an overall best practices in patient documentation in regards to emergency medical services. So documentation, unfortunately, is a skill that, well, most of us fail at. We do a really good job with our patient care, and EMS is known for the quick responses and excellent care. We really are. We're the people that get called out when things go wrong. But one of the things is we fail the very thing that proves our good care, and it's also the catalyst for how we get paid. And that skill isn't really taught in initial EMS training, but is an absolute necessity to our job. That skill is proper documentation. I remember when I went through EMT school many years ago, we didn't spend a whole lot of time on documentation. We were required to fill out a few PCRs to turn in at the end of our clinicals, and they were just kind of glanced over, and we either got a pass or a fail on it, and nobody really explained to us the right way to document. And most of my documentation that I learned over the years through trial and error. So the next few slides are going to go over documentation to give you the skills necessary to have superior documentation that will prove your excellent care and help your organization to get quickly paid for the services that you provide, and most importantly, to protect you in the unlikely event that you were to end up in a court of law. Here we go. Speaking of, documentation is a record that can keep you out of court and potentially out of trouble. Write every report in a manner that you think a judge and jury might read it. And that was one of the best pieces of advice I ever got by a good friend of mine who's unfortunately passed away, by the name of David Ferris. He's like, hey, write it like you think a judge and jury will read it. Your documentation can be presented as evidence, and that documentation could be the difference in a potential judgment against you or somebody that's involved with that scene that you went to. The patient care report is a legal document of the patient encounter. It records what we found during the assessment and the skills we performed and why we performed those skills. Poor documentation opens up areas for liability. So always remember that. Write clear, concise documentation that easily paints a picture of the encounter. And we're going to talk a little bit about how to do that. So good documentation proves that quality patient care that was performed. It should clearly show an overall picture of the patient encounter, exactly what happened. It should just paint a picture of exactly what happened. It's just like reading the paper. When you're reading about something, it's very clear, it's concise, you know exactly what's happening. So it should be easy to read. It should be concise, thorough. It should show the complaint, that we performed proper assessment, the treatments and the response to those treatments. In this training, we will focus on the narrative and not on the tabs of the report. All right. If I try to go on tabs, because this training is presented to different services who use a variety of different companies to do their reporting, this training would be several hours long. And so what I want to talk about today is specifically the narrative. We're going to talk about writing the narrative, is because that's the meat and potatoes of what we do. If you're looking for questions and answers specifically to your documentation software that you use, please reach out to me. I'd be more than happy to help walk you through that. I'm quite familiar with most of those systems. So paper documents. There are a few people who still write paper documents, and I'm telling you right now, it's archaic, it's ancient. We shouldn't be doing that. The only time that we should be using paper documentation now is if our primary system of documentation, which is the electronic medical record, has failed. And that does happen from time to time. If this does happen, we do have to write, a narrative. We have to write some notes down about the patient, everything. That documentation should be scanned and added to the EMR once it's back up, and we should put that as an amended report within that and stating that, yes, we did have to write this on paper initially because there was computer failure, whatever. However, we should not just be using paper documents as an excuse because we don't want to learn how to use electronic medical reporting. So paper documentation, anytime that we have any type of paperwork, it should be scanned in and sent in with that report. One of the things I get asked quite a bit, and people are quite shocked at the answer to this, is yes, indeed, people do use their personal computers to write reports, to access patient documentation, and I'm telling you, you're cruising for a bruising when you do that. And what I mean by that is your computer more than likely does not meet um, the electronic listing for your company for HIPAA compliance. Believe it or not, your organization has to list every piece of equipment that is used for patient documentation. All right. If you are using that to do documentation for that patient or whatever, and it's not HIPAA compliant, there's chances are that malware, viruses that could be on your computer that could potentially capture that patient data and open up your organization to a breach with HIPAA. And that means if there is a breach of information, everything, your computer and everything on it could be used in potential litigation for that breach. It could be used as a source and everything. I'm here to tell you, just don't do it. Use your company's HIPAA compliant electronic source for doing that documentation. Do not use it on your computer. So we're going to take a look at some formats for writing. It'll be helpful to kind of remind you of the way to write. And so these are called documentation formats. Let's take a look at them. This one's called a chart or chart. And a lot of people in EMS do use chart or a chart to write. You may have learned it through school and different things. And so we're going to look at it through a chart, but you can just use chart. And A stands for arrival. That's your dispatch information, what you were called out for, how you got to the scene, how you responded. C is for your complaint. So it's exactly what it stands for, exactly what the patient states is going on. H is the history of that patient. A is the assessment, the things that you find. R, which stands for RX or treatment, is what you did for that patient based off of their complaint. And T is transport, is how you got them to the hospital. SOAP, which is what I like to write, is SOAP notes. And I started doing that when I started working offshore and working overseas in small clinics in occupational medicine, was to write SOAP notes, is because that's what the physicians and the other providers wrote. S is for subjective. This is basically from that patient's point of view, what they're telling you, what their complaint is. O is objective. These are the things that we find or the things that we look at. A is the assessment. These are like, where we're actually touching the patient, we're grabbing vital signs and different things like that. And P is the plan, what we did for them, what treatments were initiated, what were the response to those treatments, did we transport, did we move them to another provider or whatever. And SOAP is pretty common formatting within medicine. Another one that's kind of new is called DRAT. And D is for dispatch, which is pretty similar to the A chart, is exactly what you were called for, how you responded, which goes into the R for the response. A is for arrival. So the DRA is kind of all put together. A is for the assessment, which is finding the chief complaint, going through and doing an assessment and a workup. T is for treatment, what you did for that patient, what were the responses to that treatment, and T, of course, is for transport, where we took them. Writing a good narrative. So when we're talking about writing a good narrative, let's look about things about what not to write. And this is important. Just as it is important to know what to write, learning about what not to write is just as important. So write like a pro. You are a EMS professional, no matter what your level, if you're EMR, EMT, whatever you are, you should write like a professional. And if your name's on that report, you should look at that report. So I have like drivers and take a look at that report. If you want to see that, even though it's not technically your patient, um, absolutely look at that report to see if it matches up with what you saw and what you did and ask questions. It's a team sport, folks, that we work at. So one of the big things is spelling is part of good documentation. There is nothing wrong with using spell check, using Grammarly and things like that to make sure that we sound professional, that we look professional. One of the big things that I see on a lot of reports over the years is O2 saturation, spelled STAT. It's not stat, folks. Stat means we get there quickly. Saturation means SpO2, because that's what we're looking at, is a saturation of a hemoglobin. So take a look at those things, that may be common mistakes. Make sure we use proper medical terminology. All right. And this is important is because we've studied medical terminology to become a part of EMS, and we should be using this as part of our documentation. Use anatomical landmarks and anatomical terminology to describe locations. Make sure that you're using things like lateral, medial, all of those good things. So what do we do for them? And this is the big question. Not only for, if we get into a little bit of legal problems later on down the line, we have to paint a clear picture of why we did something for this patient. What services do we provide for them? And this is important for insurance companies. They want to know, well, what did you do for them? We should be doing something for these patients. We should not just be giving them a ride, throwing them in the back. That's what Uber is for. We're EMS. We treat patients, right? What that patient needed and what the outcome was. Look at the assessment. Okay, I have a patient who has low blood sugar, and we saw that their blood sugar was 50. They had the ability to swallow. We gave them some oral glucose, and their glucose came up and they were more alert. This shows, number one, that they needed an ambulance. Number two, it shows that there was a clear need for treatment. It shows a good outcome from that treatment. And this is what we should be doing for every patient, is seeing, hey, we have a need, let's meet it. Here are the reasons why we did what we did. Abbreviations. Oh my gosh, cruising for confusion. So me personally, when people come and ask me about documentation, when I put on a documentation class, is what do I think about abbreviations? I personally don't like them. I don't use them very often within my own documentation. And I want to tell you a story here in a minute just about why. So I've learned over the years to avoid them. Insurance companies don't agree to a standard of medical abbreviations, and the easiest way to ensure that they understand your report is to write in plain English. It's preferred and easy for everyone to understand. Do not use abbreviations that are not part of your organization's approved list. Now, each organization may have an approved list of abbreviations that should be found within your protocols, or a separate documentation called an approved abbreviations list. If you have one of those, you may use abbreviations as long as they were within that approved list. Don't use acronym used in school that helped you remember things like DCAT, BLS, TIC, sample, OPQRST, those different things. Those are used to jog your memory, but we shouldn't be writing those down within our documentation. Here is one I like to tell this story is try not to write the abbreviation SOB for shortness of breath. Now you'll see that and immediately know what that is. I tend to write things like dyspnea, patient, or just write it out. Patient complains of shortness of breath or respiratory um, difficulty because it shows a clear description of a medical problem. Now, I was an ambulance director a couple of years ago, and I got a really nasty phone call after a patient had gone to medical records at the hospital and got a copy of the report. And this patient, one of my staff members, had wrote SOB on there for shortness of breath. A great provider, and the family was quite upset. And I took the phone call and wanted to know why one of my blankety blank paramedics thought it would be real funny to call their grandfather an SOB. Uh, it really took me back, and I had to explain, that that was an acronym. They told me that it wasn't a good acronym, and I believed them. And so immediately, we had a meeting with all staff to not use that. It was quite an ordeal to explain that and to get that family to calm down. Lots of abbreviations can have various meanings and can be subjected by the viewer, so just avoid them to avoid confusion. A good example is MS. How much stuff could this stand for? It can stand for Mississippi. It can stand for multiple sclerosis. It can stand for MIS. It can stand for morphine sulfate. A lot of things can be confused for that. So I want people to understand why it's so important to write a plain English, clear report. At one time, I was drug into court. Um, Part of the discovery and everything for an accident, and it happened a couple of years prior to it going to court. During the discovery phase is where they gathered all the information and stuff. I was quite frightened, and I got sat down with a couple of different attorneys, one from each side. They read the report. They all understood it. It's because it was clear, it was concise, it was in plain English, and without they didn't have any questions about it. And that case was actually thrown out of court because of the reporting that I did, is because it was clear, it was concise, there was an easy picture to be seen. And believe it or not, it confirmed my faith in leaving out the abbreviations and doing good, clean documentation. So one of the things we need to think about here is the location necessary? And I think I'm not going to tell you not to write this, but I want you to understand writing a patient is it necessary? All right. Does it add to the picture, or is it just adding something that may cause confusion? Writing that a patient was found sitting, unless it's pertinent to the patient condition. For example, a person sitting up in their chair with abdominal pain at home that was a sudden onset, that's important. But if we write a patient was sitting, standing, walking, or whatever, be prepared that an insurance company may deny the claim because they say the patient can go by automobile. If the patient walking, standing, or whatever is pertinent to what's going on, it's absolutely. But if the patient is walking around and there's nothing wrong with them, or they're able to go by car or whatever, you have to write that. We're not going to lie on reports. We're certainly not going to do anything fraudulent. But sometimes we don't want to cause confusion. There are really only a few times that my own documentation, a patient position is important and should be documented. Here's a few examples. For trauma, the patient's ambulatory, the position found, where, do they have a gunshot wound, crime scenes, victims, falls, etc. We should put out where they're located. Are they laying on the ground? Are they going to supine, a prone position? Are they ambulatory? That means they're walking around after an accident. All of these things are important. Is the patient unresponsive? Where was the patient found in their positioning? This is important. So one of the other things that's real important is anytime we have patients who have a complaint of respiratory issues, we should talk about their positioning. Are they using like accessory muscles? Are they in a tripod position? What are they doing? Are they laying down? Are they finding it more difficult laying down versus sitting up? All of those things are important. And so that, I believe, goes along that the location of the patient is necessary. All right. Another thing to be careful of, don't write dirty words in your narrative. Oh my goodness. Just because the patient stated it doesn't mean that you need to write it. Yes, that patient called you something awful, and yes, the patient did state that. You can put it in quotes. Writing the patient stated that in writing out is unprofessional, and the folks who read it are not going to be very impressed with your comical stylings. We should only write that the patient stated in the context of patient care. All right, so the patient called me some really dirty names and everything. I can write what state that patient is in without belittling the report by writing a bunch of foul language in it. It's more professional to write that the patient was belligerent, uncooperative, combative. We write a medical report, not a police report. The only time that I think that it is acceptable to write that is when the patient is threatening violence. They're stating things about threatening violence to other people, threats, to staff, different things, or they're talking about like things associated with crime. All of that stuff should definitely be documented in the direct patient quotes. But be professional, please, when we're writing these reports. Oh, pet peeve of mine is writing the term treated per protocol. Number one, the people who may read this, especially if you're going before an attorney, a judge, a jury, or anything, and you write down patient treated per protocol, you better know that protocol inside out, word per word, is because that's what they're going to judge you on. Is that you treated it per protocol, word per word, and it better line up exactly within your documentation. So be careful. Most of us know our protocols pretty well, but very few of us know them word per word. It's better that we write down the interventions that we performed in the order that we performed them. Write down any changes to an intervention. I started an IV, there were no changes. For example, if a patient has low oxygen saturation and you put them on oxygen, you should write down how much you gave, the delivery device, and if the saturation improves or worsens or stays the same. This is good care. Same goes for all interventions. Write down what you did and what the outcome is for that intervention. The patient's chief complaint and the findings of your assessment should clearly point to the reason why you are performing an intervention. So I can't just do an intervention is because, well, it's protocol. There has to be a clear reason why. All right. I can't give aspirin, nitroglycerin, and potentially a pain medication just because I think it's a great idea. No, that patient has to have a complaint of chest pain in order for that stuff to go along. So I have to prove why I'm doing what I'm doing. Show that you are a clinician and making a clinical decision, making and not just going, well, this fits into a protocol, so I'm just going to drop it into here. No, we have to have a good reason why we're doing things. You know the protocol. The person reading it more than likely does not. However, they're going to find out what that protocol is. And if you have to stand before a judge and jury, you are going to get grilled on that protocol. So the best thing is to write why you did something. Does it make clinical sense? Was there a good reason for something that you found in the assessment for why you performed an intervention? Speaking of protocols, if a protocol tells you to do something, then you should be following those steps, and all those assessments and interventions should be performed. If your agency does not have a paper copy of the protocols in each truck, I highly recommend that you talk to your agency's leadership about doing that. That way you have a resource to look at. If you could perform items in the protocol or had to do something outside of the protocol, it should be documented. All right. If I have a patient who has chest pain, all right, and let's say that they're taking a medication that is contraindicated by one of the medications that I would give, such as nitroglycerin, I'm going to write why I did not give the nitroglycerin is because of this. Whew, all right, lots of stuff here. One of the things that I highly recommend, and this is a best practice across the industry. I read a great article by Page and Worth. They are EMS attorneys, and this is all they handle is EMS stuff. And they were talking about why it's important to document vital signs within our narrative. And so let's look at that. There are tabs for vitals, but a set of baseline vitals should be included in the narrative. Every report should have at least one set of vitals. The vitals in the narrative gives us a basis of the cardiovascular, respiratory, neuro, and endocrine status of the patient and gives us indications for why we're doing certain interventions. It shows in the narrative that we are performing a good exam. When you have changes in vitals from interventions such as a fluid bolus, medications, glucose, for example, you will document the initial vitals and then show how that vital sign changed after your intervention. Don't write patients have stable vital signs or vital signs within normal limits. Because if you unfortunately come before a judge or jury, you're going to have to explain exactly what normal limits are within vital signs. Because what's considered normal may not be normal for that patient. So be careful by using that. Prove it. Show stable vital signs if they are present. Show why you do things. Show that you're digging in deep to find out what's going on with that patient, and you are treating based off of those assessments. Write the vital signs. It's good. It's just a good idea. Don't say alert if they have a GCS of less than 15. 15 is alert. Hands down, it's alert. GCS of 15. Right now, I have a GCS of 15. I'm talking. I have my sensorium is normal. The table that I'm looking at here in my living room, I can not in the living room, but in our dining room right here, it's all connected. That table has a GCS of 3. So know the difference. One common finding on many reports is verbiage that does not match up with patient conditions and vital signs. If you write that a person is alert, then they cannot have a GCS of 13 and be alert. That's not alert. They are verbal. They are only alert if the patient has a GCS of 15 and has no alteration in their mental status, even if it's their normal mentation. So you can have patients that have a GCS of 14 that are in the nursing home, because they're confused normally, maybe due to things like Alzheimer's and different things like that. Do not write any changes noted or no change in vital signs when your documentation clearly shows a change in vital signs. Documentation should absolutely match up from tabs to the narrative. You should be able to go back and forth and they should 100% match up. So what if you can't get something? What if you can't get vitals? What if you can't get the patient's information or whatever? Should you just write unable to obtain mount and just move on? Absolutely not. If you are unable to do something or you're not able to gather information, then write why that happened. Very clearly, just writing unable to obtain gives no indication of why and opens up areas of liability. If I can't get the patient to sign our documentation, maybe because they're altered, maybe that patient has been drinking heavily, they're quite intoxicated, and they are confused. That means they've got a GCS of 14. I'm going to write why that patient can't sign. it's not just unable to obtain is because the patient's too damn drunk to sign that, but I should be able to clearly explain exactly why I'm unable to obtain certain things. So now let's kind of change directions here and talk about good documentation and how to write a narrative like a champ. Hopefully by the end of this video, you'll pick up some tips and some tricks on how to write a good narrative. Now, every organization may have different things that they want you to write in each narrative. I know, like agencies that I've been associated with over the years have had different ways of things that they want in their documentation. And what this is kind of a mashup of all of these different things that makes up good documentation. And so I want to share it with you. So, number one, what is the call? Why are we going somewhere? So, place in your narrative the reason you were responding. The reason we're responding more than likely is because we got a 911 call or dispatch advised us that we're to report to this facility to go to another facility or to grab a patient and take them home. Include what you were dispatched for according to dispatch. Where and how you responded is very important. Start off with the mental status in GCS is because this shows us very clearly if that patient is not alert, that there is a reason that they're going to need medical care. So a mental status that is less than alert and less than 15 proves the patient requires an ambulance, very simply. There is an important finding in any encounter and shows a neuro exam was performed right off the bat. On a non-emergency transport, you have a patient with a history of Alzheimer's, dementia. Writing confused patient with a GCS of 14 helps to show a good assessment that helps us to secure payment because it shows the patient is altered and will require 24-hour supervision. This simple phrase sets the stage for our care by identifying neural and mental status. Very simple. All right, let's look at skin color and condition. This is also very important. All patients should have their skin color and condition assessed as part of the normal assessment that we perform. We should be looking at their skin is because it tells us a lot about their cardiovascular system, quite honestly. Skin changes such as pale, ashen, cyanotic, red, hot, cool, dry, diaphoretic, etc. also changes in underlying systems and are an important finding and should be documented on every patient within the narrative. Documenting this will give the reader of the narrative a clear picture of what that patient looks like. So let's take a look at the eyes. The eyes have been described as the windows of the soul. Checking pupils should be part of most exams, especially anything that involves neuro. If we have patients who are diabetic and are hypoglycemic, check pupillary response and size and note it on the narrative. This is part of a normal neuro exam. It indicates what is going on in the central nervous system. Pinpoint pupils could show narcotics. Dilated pupils could indicate other substances or seizures. Unequal or sluggish pupils could indicate a central nervous system problem such as a stroke, a bleed, significant head trauma, etc. It only takes a second to check it, and it should be performed on every patient if possible. The chief complaint. What chief complaint is what the patient tells you. If the patient is unresponsive, the chief complaint is what you find in the assessment. Write down the patient's chief complaint and then build a focused exam or do a trauma exam for a trauma patient. Once a chief complaint is obtained, it will help us to do a focused exam and really kind of hone in on that patient's problem. For example, if we have a patient who has abdominal pain, we're going to focus more on the abdomen than some of the other systems. The exam we perform should really be based off of that complaint that we're building off of. Most times, what we are dispatched for is not the complaint of the patient. So, ask lots and lots of questions. So, I see this with a lot of new providers, new EMTs, and new paramedics, is they depend too much on the dispatch information. Well, dispatch said that they're having abdominal pain. We get there, they're not having abdominal pain, they're just nauseated. Different things that we should be asking. We should be asking lots and lots and lots of questions. So if we are documenting and we forget something, maybe we've already turned our document in, we've already hit submit, and it's gone through, can we get a supervisor to unlock that document and us to add something in the narrative? Yes. However, you cannot go back and change the narrative. Once it has been locked up under that, what you should do is below the narrative that you wrote, you should write the words amended, put the date, and then write whatever things that you need to add to it. So always write, again, amended, the date, and then whatever you wanted to add to it. So let's look at some things that are focused documentation based off of a few different complaints that are pretty common for us. Any complaint that has pain as a component, we should be using those OPQRST questions. They must be asked, and a pain scale before and after treatment is indicated. So, onset. When did that pain start? Was it sudden? Was it slow? What time of day it was. P is provokes. Does anything make it better or worse? Q is quality, which is it sharp, dull, stabbing, pressure? Is it constant? R is for radiate. Does the pain go anywhere? A good one is for chest pain. Does it go under your arms or your jaw? And S is that severity. And I also like to say S is for the scale, which is that pain scale of 1 to 10, or you can use faces, the Baker faces scale. The one thing it's called Long Baker, is it has little happy faces and sad faces on it. T is for time. When did the pain begin and how long has it been going on for? All of these questions are very important to build exactly what is going on with that patient and what interventions we need to do for them. So for abdominal pain, GI complaints, OPQRST on all pain complaints, all of them. An assessment of the general abdomen. So is that belly soft? All right. So we press on it. Is it soft? Is it distended? Is there any rigidity? Is there tenderness? Is the patient guarding? Inspect and palpate all 4 quadrants and make notes on all 4 of the quadrants on the assessment we did. Listen for bowel sounds and document. Does the patient have nausea or vomiting? If that patient does have vomiting, does it look like it has blood in it? What does it look like? What does it appear with? Bloody or tarry stools. When was the last bowel movement that patient had? Their last oral intake, their last bowel movement, any bleeding noted. Another thing to ask, which is very, very important for female patients, is their last known menstrual cycle, any changes to it, any thoughts they may be pregnant, or is there any bleeding noted? When you're pressing on the belly, is there a potential for a pulsatile mass? That patient could potentially have a AAA. Are they vomiting copious amounts of blood? Could we be thinking about esophageal varices? If we think that patient may have a complaint that is going to be needed to be resolved surgically, it may be a good idea to ask what their blood type is. Respiratory complaints, part 1. We run a lot of respiratory patients. It's a really common EMS call. It's right up there, not nearly as many respiratory complaints as there are mental health complaints, but they're up there quite a bit. Is that patient positioning? Are they having muscle retractions, accessory muscle use, nasal flaring? Are they getting good air movement in? Make sure you auscultate all, which is listening to all lung fields and note the sounds that you hear. Make sure that we obtain a SpO2 before and after oxygen and drugs. Note the delivery system and the amount of oxygen. One of the other things that I highly recommend is with a component of SpO2, if you do have it available. The nasal cannula CO2 is also very useful information at this point. If they have any pain when they're breathing, again, those OPQRST questions come right into place. So ask, does sitting up help? Now, this is important, especially if you have patients that are in heart failure. A lot of times sitting up helps. Do they have a productive cough? That means, are they producing any sputum when they're coughing? Are there wet lung sounds? If there is, check for jugular vein distension and pitting edema. So look down there at their ankles and their feet. Bilateral sounds. If we only have it on one side and not another, if we only have breath sounds on one side, is a pneumothorax possible? Any tracheal deviation? Please note, of course, that tracheal deviation is a late sign with a pneumothorax. If a patient is in severe dyspnea or pulmonary edema, consider CPAP and note improvement and the settings that you're going to be using for CPAP. So part two, if the patient deteriorates and needs an airway, we need to know what those deterioration signs and symptoms are. For our paramedics that are out there, if you're going to be considering intubation, an airway score and difficulty and adjuncts used is very important. So especially if I'm going to be thinking about rapid sequence intubation, I want to know what my mouth patty score is and be looking and thinking about what difficulty that I'm going to be looking at. For intubation, the paramedic should get 2 attempts and go to a biad. It must be inserted, no excuses. We certainly don't want to try being a hero and just trying to tube over and over again and causing hypoxia. 2 attempts and then a biad is perfectly acceptable. If we are successful in passing an endotracheal tube, we must ensure that we visualize passing through the vocal cords. Bilateral breath sounds, absent gastric sounds, chest rise and fall. There's no belly expansion. Color change on colorimetric CO2 detector if available, or a bulb syringe. End tidal and SpO2 on all patients should be observed and documented. Bag valve mask with how much oxygen and rate of breaths, or your ventilator settings. Document how the tube was secured, the tube size and insertion by the number at the tip, usually by 22. A good rule of thumb to be able to figure out how deep to insert an ET tube is to take the tube size and multiply it by 3. Airway must be confirmed by a doctor and document that the airways was confirmed in the ER, that you did bring the airway is and it was confirmed to be a good airway. Respiratory part 3, the ventilator patient, if you do get one of these. Documentation, the verification of the airway before and after the patient is moved bed to bed. That means it has to be confirmed at the scene and again at the destination. Document those vent settings. Place in the tabs and also in the narrative. Document breath sounds, the tube depth, or other pertinent information. End tidal and SpO2 is required on all vent patients. Airway confirmation signature is required. A nurse can sign the airway confirmation as long as we didn't place the airway. If we intubated or put a biad in, then an MD should sign if at all possible. The reason for that is we don't want to place an airway in and it get dislodged, after we've already left, and us to get blamed for the dislodgement of it. Now, if we dislodge it on the way over there and it's not in, that's fine. That does happen sometimes, but we want to make a clear delineation that this is our airway. This is somebody else taking over that airway. Chest pain. Yep, it says pain. And so we're going to ask those OPQRST questions. We're going to get that pain scale from 1 to 10. And we're also going to ask about associated symptoms such as diaphoresis, shortness of breath, nausea, and vomiting. A 12 lead, documentation, transmission to the emergency department. Repeat the 12 lead if applicable. A 12 lead should be done on all patients, preferably in the house at the time that we arrive on scene. Is a 12 lead should be performed. A good recommendation, man, is a 12 lead should be performed within the first 5 minutes of greeting the patient. Is we should obtain a 12 lead. Make sure we transmit that and repeat as necessary. So we're going to palpate and see if there's any chest wall tenderness. We're going to listen for heart tones, looking and seeing if S1 and S2 is there. If we do see on the EKG that we have signs and symptoms of an acute myocardial infarction, STEMI, call the emergency department immediately and call a STEMI alert and document. So chest pain, did we perform an IV? If we did, we need to put, what size, the location, any fluids in the responses, any medications that we have given, and also those responses is, the basic treatment for chest pain includes aspirin, nitroglycerin, sometimes pain medications. In certain places, they even give go ahead and start other therapies such as heparin. We need to note that. Does the patient have relief of nitro? This is a very important finding. We need to document that. So if we do have a patient with AMI, STEMI, a thrombolytics checklist should be performed in all chest pain and stroke patients. If you don't have a thrombolytics checklist at your organization, get with your hospital. Get a thrombolytics checklist, man. They would really appreciate, number one, that you're interested in having that. But if we can fill that out on the way, this helps shorten some of the time that patient is going without treatment. Is if we can shorten that out, get that documentation done on the way and hand that off to a nurse or a physician, this shortens that treatment time. The AMI tab and thrombolytics should be completely filled out as part of your documentation. Document before and after the pain scale, before and after nitro, morphine, or other medication that is administered. So now we're moving on from our patients with chest complaints to stroke. Super, super important. The documentation that we have for stroke is because it can really illuminate why this patient is a stroke alert, why they're a candidate for certain medications and treatment. And so it's important. So first thing is the time of onset. When do these symptoms begin? Or if we are unsure when the symptoms began, when was the last time that patient was known to be well? What symptoms is the patient experiencing? Do they have facial drooping? Do they have paralysis, different things? Did those symptoms resolve? Was there any trauma noted prior to these symptoms or recently? Patient's glucose level, super, super important about their glucose level. It should be obtained as part of our normal care, and is important to document is because patients who are hypoglycemic may exhibit stroke-like symptoms. Has the stroke team been activated? You need to document exactly what time you called. So patients who unfortunately go into cardiac arrest, what time was the onset of symptoms? Was the arrest witnessed? What time was CPR started and who was it initiated by? Was a Lucas or other device used in place of manual CPR? Was there an AED used or a defibrillator? So in cardiac arrest, we want to know interventions and responses, exactly what we did, the times that we did it, and did the patient get better or worse, stay the same. One of the things that I highly recommend for all organizations, when they are writing their protocols, you should be reviewing your protocols at least annually. And this should happen within the organization is your senior management, your administrators should be reviewing protocols. And then when they roll it out, they should have a protocol review every year with all of the staff to ensure that everybody matches up. And within that is we want to make sure that our protocols are embracing the current science. And the current science, as far as cardiac arrest management, is through the guidelines of the American Heart Association. And we need to ask ourselves, does our protocols, does our treatment match up with the AHA guidelines? Don't forget those H's and T's when we're in cardiac arrest management. This is going to be something that you guys are probably familiar with if you've taken advanced cardiac life support, ACLS. Did we have ROSC, return of spontaneous circulation, which is what we're hoping for? If we do have ROSC, fantastic. If so, what interventions did we perform past ROSC? Did we go ahead and place an airway? Include the EKG in the report in your interpretation. So now moving on, we're looking at trauma. So trauma is one that we should document generously when it comes down to trauma, especially with workplace accidents. We should definitely document quite a bit. Any trauma that involves like car wrecks and things is because there's a lot on the line with this. And so we need to look at things and ask, all right, have we documented the mechanism of injury? The position of the patient. Again, we talked about that earlier. Is it pertinent? And in this case, absolutely. Selective spinal immobilization. Was spinal immobilization indicated? What tools do we use to immobilize that patient? All right. We want to know about the protective equipment used by that patient. We want to do a head-to-toe survey. And if that patient meets criteria, did we activate the trauma team and at what time? And we want to describe those injuries in detail, definitely using good medical terminology and anatomical landmarks as we document. One of the things that scares me, not only as an educator, which is kind of what I do now, but as a still working as a clinician, but also in my past as an ambulance director, is refusals. Of all the things that we do, the thing that puts us at most risk for litigation as an organization is a refusal. So we should document, document, document. Do a thorough assessment and document the findings. If the patient refuses assessment or treatments, thoroughly document what care you offered. Hey, I think you need to go to the hospital. These are the things that I think that you need, why you thought it was necessary. And if the patient refuses, make sure the patient understands the risk of refusal and put down that the patient is aware of the risk of it and still decided to refuse. Make sure every section on a refusal document is filled out, signed, and preferably witnessed, especially on high risk refusals like patients who are belligerent on the scene and stuff. Get law enforcement or somebody to witness that refusal. Very, very important. So one of the things that gets a lot of agencies and their providers in hot water is allowing a patient to refuse care who is not in the best judgment to refuse care. If in doubt, call medical control, get other people involved. All right. It's always better to go over and above when it comes to this stuff. Number one, are they old enough? Have they met your specific state requirement for the age of consent and refusal? Are they within their right frame of mind? Okay. And when we ask this, are they able to make medical decisions for themselves. And this is more than are they alert and oriented times 4 with a GCS of 15. There are plenty of patients who are alert and oriented times 4, but are they able to make their right decisions? Are they under the influence of mind altering substances? If this patient is suspected of being intoxicated, they are not in their right frame of mind. And if you are going to allow that patient to refuse care, you're walking on a dangerous tightrope. Because how can you, without lab equipment, to be able to determine that they are specifically intoxicated? We know that an intoxicated person is not a good historian. If we find them, just lethargic out on the street, they look appear intoxicated. How do we know they didn't fall and hit their head? How do we know that something else is not going on? We can't. And so we need to make good judgment with that. Do they have a GCS of 15? If it's less than 15, man, you need to go ahead and be considering transport. Have they suffered a serious injury or illness that could cloud their judgment? If any of these things come into play, it's always better to try to get them to go to the hospital. And if they are still refusing, it may be a case where we get medical control or even law enforcement involved. Big warning here. Patients who refuse care can place a high risk of future litigation, as they may be out of their mind now and they think it's the best decision for them. But once their mind gets cleared up and they figured out an ambulance came, or their family figures out an ambulance came, and that patient was worse off than they thought, and we didn't take them to the hospital, even though they said they didn't want it to begin with, they could turn it around on you real quick. I've seen that happen. Be prepared to write why they wish to refuse. Why do you not want to go to the hospital? What care you recommended, and that you told the patient of the potential outcomes of refusing their care. I give them a warning. Hey, I recommend that you go to the hospital to be evaluated. I've only got so much equipment in this truck. I can't 100% tell you that everything is going to be fine. There's limited equipment that I have. I think it's always best that a patient go to be evaluated. And so I try to talk patients into going to the hospital. I know many providers that are out there that do the opposite, is they try to talk a patient out of going to the hospital. And I'm going to tell you right now, it's dumb. Don't do it. Either way, you're going to have to write a report that's just as lengthy and everything. And for me, I would much rather have to write a report for taking a patient to the hospital than have to explain why the patient didn't want to go or why I talked them into not going. My job is to take care of patients and to transport them to the hospital. My job is not to try to talk them out of doing that. If that is something that you're currently doing or involved in, get out of that mindset really, really quickly, as it could land you in hot water. Patients have rights. Absolutely. Patients have rights. A patient may refuse all care. I don't want you to do anything. I just want to ride to the hospital. I'll let the hospital do everything. And that is totally within their rights, but we want to make sure that we write that refusal, get them to sign that, and also write down exactly what they didn't want. Patients may refuse parts of care. One of the big ones that I see, especially in EMS circles, is that patients may not want an IV started. Maybe they're frightened of IVs. Maybe they've had bad experiences in the past. And if they don't want that, it's perfectly okay. They have the right to refuse certain aspects of our care, and we can still offer them other parts of care and transportation to the hospital. And again, the patient may request only transport. All right. One of the things that we're going to run a whole lot of, I wish, we just wasn't, when I talk to EMS providers, they're like, oh my gosh, I can't stand doing transfers, discharges, and appointments. It's part of what we do. And so we just should accept it. So a transfer. All transfers should have the following. We should have a face sheet This is a demographic sheet, which basically has their general demographics. Should have their name, their date of birth, their address, phone number, and their insurance information. All right. We should also have documentation should be found in the chart on which physician sent them and why they are going. One of the things that has always bothered me is going to a facility and they'll give you a packet of paperwork and you look in there and all they've got is a transfer sheet and the PCS and a face sheet. You ask the patient what's going on and they are completely dumbfounded. They just know they're going to a certain facility and have no idea. You need to get an H&P. All right. Ask for the history sheet. Know what drugs have been administered, lab work. Look at the physician's notes, the provider's notes, and see exactly what they were there for, what they were diagnosed with. Look and see, what the results are from different imaging and things. We should get that is because that documentation, as we are using that, to write in our own documentation helps us to paint a very clear picture of exactly why that patient is being transported from one facility to the next. So now let's talk about the PCS. The PCS is a required document that lets the ambulance company know and also insurance providers, billing, senators from Medicare and Medicaid, they need to know exactly that this was medically necessary. The PCS should accurately describe why the patient is going to another facility and the reason, such as upgrading care for surgical services, ICU bed is unavailable, cardiac services, etc. If it's not on the PCS, right? If the PCS is blank or whatever, politely ask the nurse to document it on the PCS. Make sure that the PCS is signed by an RN, MD, other staff members that can sign this PCS, and that it is filled out with the patient demographics, or at the very least has a label on it. Most of our hospitals and things that we're going to pick up at is going to have a PCS. It's just going to have the patient label on there, and that is completely okay. Check that face sheet before you leave. Just don't grab it and then take off, because you could potentially have the face sheet for a different patient. That happens. They do get mixed up. Sometimes hospitals and other healthcare facilities will give us a blank face sheet or one with missing information, like no insurance information. Just ask. If the patient doesn't have insurance and the facility tells you that, well, you know why it's blank. If not, maybe they were not able to obtain it or whatever. And they say, hey, we just didn't get it. We're in a hurry or whatever. We know that. So try to find out why. Try to gain insurance information from the hospital before leaving. If not on the face sheet, it's always easier for us to get it at the source and for the billing department to try and track it down. Don't be lazy. Don't mark unable to obtain because you didn't make an effort to gather up billing information. Billing information is important. It's how we get paid, dude. And it should be a priority. As much as we have a priority of care and everything, we want to make sure that we're getting compensated for our care that we provide. All transfers should have the following documented: the reason for the ER visit or the hospital admission, why they were there, what they came in for, the reason for the transfer. So let's take a look at this. Let's say we have a patient who came in for abdominal pain and they noted that they have a bowel obstruction. The reason for the transfer is that maybe this hospital doesn't have surgical or GI services. We write about any necessary medical equipment that is needed for the transfer, such as maintaining an IV, any medications we're maintaining or administering. Does the patient have NG, OG tubes, Foley catheters, PEG tubes? Is the patient on a ventilator? Are there central lines, PICC lines? Does the patient have specialty equipment such as a VAD, external defibrillators, etc.? IV should be documented that they were maintained and how much fluid was given. Be careful. All right. Know what your local protocols are as far as what levels are okay to be maintaining IV medications. Know what IV meds that you can take, what IV fluids you can take, and just be careful, is because you could be taking a transfer and doing something that is very much outside of your scope of practice. So make sure you know what your scope of practice is and that you are following that. If drugs are maintained, it should be documented in the IV section and also in the medication tab under other, because sometimes the tabs for different programs may not have a specific tab for medications that we're taking. Let's say that we're taking an ANSEF drip out of the hospital, and you're looking in the IV tab and the medication tab, and ANSEF is not listed there. So just go to other, and in the tab that pops up there, just write ANSEF, how much you give. If there's not a tab for that, just simply write it in the narrative. They should be placed in the narrative regardless. So psych transfers. You're going to do a lot of those in your career. You're going to do psychiatric transfers. There's more psych patients in our facilities. In addition to the regular documentation necessary for a transfer, we should document the signs and symptoms associated with the transfer to prove the patient requires either ALS or BLS monitoring, such as suicidal ideation and intents for self-harm. They're going to require continuous monitoring. Are they delusional? Are they having hallucinations, either visual or auditory? Are there any other signs or symptoms associated with the psychiatric patient? And then lastly, what did we do for the patient? Did we just give them a ride? Never. We always do something. It could be simply that we monitor the patient. We're doing something. We're monitoring the patient. We're providing one-on-one care. These are things that we should be writing down that we are doing. All right. Whatever that we are doing for that patient should be documented. So you may not have this in some of the rural places and stuff, but this documentation course is made for all different types of services. And in some of the cities, they do cath lab to cath lab or hospital that has same or similar care. So let's say if it's a stat transfer from one cath lab to a hospital with another cath lab, it could be because that hospital's cath lab is only there to do diagnostic care and not able to do further care. And so you may skip that. So what if you are transferring a patient from one hospital to another hospital and they have very similar capabilities? Well, we need to write down exactly why we're taking them. Does your hospital not have bed space available? Whatever's going on, we need to know that. And it's going to make sense as to reason that patient needs an ambulance and why they need to go there. Quite often, the reason initiating lab hospital only does, which we talked a little bit about with the cath lab, but let's say that your hospital is transferring a patient out is simply because they don't have enough bed space to house this patient. Perfectly acceptable reason to transfer that patient. That patient is going to require monitoring and that there is no bed available. Great. We can send that patient to another facility that is of similar operations as the facility that they're being sent from, and that is an okay reason. We're going to run non-emergency calls. That's all right. Our documentation has to be clear as to why the patient needs an ambulance and isn't medically necessary. And one of the things that we have to understand is we are going to get calls where that patient can absolutely be transported by other means. If that is the case, do not lie for an organization. Do not lie to try to get this call paid for. You write what you see, exactly what's going on, paint a clear and concise picture of what's happening. All big bold letters there. Non-emergency transports originating from a hospital require documentation by the hospital why the transport is medically necessary, and it should be listed on the PCS. It's a requirement. Ensure that the staff documents why the patient requires an ambulance. Sometimes the doctor may tell the nurse, call the hospital, call the ambulance. That's how the patient got here. That's how they're going home. May not be medically necessary, but the hospital ordered that. They're the ones that's going to sign the PCS. They're the ones that's going to have to answer for it. Sometimes they will just write bedbound requires an ambulance. If they tell us that the patient is bedbound, ask them to politely always get them to document why they're bedbound. All right. If the patient is bedbound, it's because they've had a stroke and they've got paralysis on one side and they're unable to get around. Perfect. That helps us to get paid, and it shows why that patient needs that. 99.9% of the time, the staff is usually pretty nice about helping to further document medical necessity. I always ask them. Don't be lazy, just ask. I may not know that patient, but there are going to be times where they're just going to be like, hey, they just need to ride over to the nursing home. Is because that's how they arrived at the hospital. And if that's the case, just write that down. The insurance company, the hospital, and your ambulance organization will figure that out. But you just write the truth. So document what the patient was seen or admitted for. All right, they were admitted to the ER for chest pain. Document why they require transportation. So let's say they're going back to the nursing home. Do they have poor trunk control? Do they have paralysis? They have Alzheimer's, dementia with confusion and require 24-hour supervision. If you write that a patient is confused, they must have a GCS that correlates with that assessment. A confused patient has to have a GCS of less than 15. Document the narrative, any medical condition that contributes to the patient needing an ambulance. The more documentation, the easier it is to recover from the insurance companies, and it shows the reason for that ambulance transportation. So here are a few examples there's 3 examples that I've included here, including medical trauma and a non-emergency call back to the nursing home. And I'm going to read these out to you. Now, again, please note that these are not specific to your organization. They are based off of different areas that I've worked over the years. I've been in EMS almost 30 years now, and I've worked at a lot of different places in a lot of different areas. I've worked all over the globe, and so every place does things just a little bit different. But here is some good approved practices for writing a good narrative. And so this is a medical call. So I'm going to read to you is this. Alert warning times 4, 48-year-old male with a GCS of 15. His skin is warm and pink with diaphoresis noted. Pupils are equal and reactive left and right at 4 millimeters. The patient presents with a chief complaint of a sudden onset of substernal chest pain radiating into the left arm. Pain is described as a squeezing pressure that is an 8 on the pain scale. Patient states that nothing provokes the pain and that he was watching TV when it started. Patient also states developing nausea and vomiting. Patient has no cardiac history. The BP is 168 over 96. Pulse is 124, and 12 lead EKG indicates sinus tachycardia with ST elevation noted in leads V1, V2, V3, V4, with reciprocal depression in leads 2, 3, and AVF. The monitor indicates STEMI. S1 and S2 are present without rubs or gallops. There's no jugular vein distension noted. Chest wall is tender to palpation. Respiration is 22 bilateral breath sounds are clear. The SpO2 is 93%. Glucose is 92. Place the patient on oxygen 2 liters per minute nasal cannula with the SpO2 improving to 100%. Establish an IV of normal saline at a KVO rate to the left forearm with an 18 gauge catheter times 1 attempt. Administer 324 milligrams of aspirin per oral. Administered a total of 0.04 milligrams of nitrostat tabs of relief of chest pain to a 7. Administer morphine, 6 milligrams IV with chest pain relief before. Administer 4 milligrams of Zofran IV, 12-lead transmitted to TCC, which is the Trauma Communication Center in Birmingham, and BMC Princeton, which is also a hospital in Birmingham, and patient into the STEMI system with the TCC number of 1387138. Repeated the 12-lead EKG after medication administration and no changes are noted. Transport patient to BMC Princeton, STEMI Fowler's on stretcher. Patient moved bed to bed with a draw sheet verbal report to staff. With that, it is a clear and concise picture of a patient having a heart attack, what his symptoms were, and what the outcome was a good outcome for this patient is because the patient got everything that patient needed for that care. So here's a good trauma report. Unresponsive 19-year-old female with a GCS of 3. Skin is cool, pale, and cyanotic. Pupils are fixed and dilated at 8 millimeters. Unrestrained driver ejected in a rollover single car accident. Rapid trauma assessment reveals absent breath sounds on the left side with tracheal deviation, crepitus notice on ribs 3, 4, 5, 6. Left humerus fracture, bleeding noted from the ears with positive halo test noted. BP is 82/46, pulse is 131 with EKG indicating sinus tachycardia with occasional unifocal PVCs. Respirations are 6 with breath sounds absent on the left side. SpO2 is 41%. Oropharyngeal airway inserted and ventilations began with a bag valve mask with oxygen at 15 liters per minute. Ventilations are 12 per minute. Intubated patient with a 7.5 ET tube, 24 centimeters at the lip. Verified with visualization of the cords. Colorimetric change, condensation of 2, no epigastric sounds. Breath sounds on the right, but none on the left. End tidal is 38. SpO2 improved to 91%. Continued ventilation. Chest needle decompressed in the left second intercostal space at the mid-clavicular line with a 14-gauge cath. A rush of air and blood was noted. Site was dressed with an Ashram and chest seal. Trachea returns to midline. IV access to bilateral and antecubital spaces with 16-gauge catheters. IVs in normal setting with a 500 cc bolus with pressure 96/60. Splinted left arm with a SAM splint. Patient immobilized on long backboard with a C-collar and a cervical immobilization device. Patient placed into the trauma system, TCC number 132123. Glucose is 78. 12-lead EKG indicates sinus tachycardia without XP or ST changes noted. S1 and S2 are muffled. Transported patient supine on stretcher with warming with blankets and heat turned on to counter potential hypothermia to UAB. Patient moved bed to bed with backboard. Verbal report to staff. Airway verified by the physician. UAB is a huge hospital there in Birmingham. It stands for the University of Alabama at Birmingham. All right, non-emergency transport. We have a confused and combative 99-year-old male with a GCS of 13. Skin is warm and pink. His pupils are equal and reactive left and right at 3 millimeters. He is being discharged from good old St. Elsewhere Hospital to Hardwart Acres Nursing Home after being seen in the emergency department for altered mental status and a non-productive cough. Patient has a history of dementia, is normally combative and requires 24-hour supervision and is a fall risk. BP is 140/77, pulse is 80, respirations are 16 with bilateral breath sounds that are clear. The saturation is 99% on room air, provided continuous monitoring and assessment. Place patient in position of comfort. Transport a patient to Hogwarts Acres Nursing Home without complications. Verbal report and big report to staff. Patient moved bed to bed with a draw sheet. This shows clearly that this patient needs an ambulance to transport him back. He's confused, he's combative, he's going to need care to prevent any additional harm to this patient. So now let's take a look at all of this together. We're going to summarize everything that we've learned today. Documentation is our money. Let's just face it. All right. This is the way that we get paid. Every paycheck you get, every station you stay in, every truck or equipment that you do your job in is all paid for in part or in full by transports. The catalyst for us getting paid is that documentation. It would be a whole lot easier if we had barcodes and everything and had a scanner and a cash register in the truck, but we don't. So documentation is how it gets done. It's how we make our money, plain and simple. When you document well, the higher the probability of the insurance paying for a transport. So we document, and we document well, and we document early and make sure we get it done. Documentation proves patient care. Documentation is a tool that we have to prove what we did for the patient. It records that interaction with the patient and proves that we provided good quality care. It documents the trends with the patient prior to the emergency department arrival. It serves as a story for why we provided intervention. Good care, but bad documentation will make you appear as a poor provider. It doesn't matter how good you are, if so let it be written, so let it be done. Make sure that if you provide good care, you provide good documentation. We want to do good documentation to prevent litigation. The patient care report is the timeline and story of all the events that occur between the onset of care to the turnover at the destination facility. That PCR is a legal document and can be brought into court as evidence. So we want to write every document like it may be presented as evidence, is because it could be. Excellent documentation can and will save you in a potential lawsuit. Poor documentation can potentially place you at risk of being named in a lawsuit and potentially being found guilty. I've seen guys get popped on documentation. There are cases in EMS world all the time talking about it. If you don't, subscribe to EMS world, through some of their social media stuff, do it. You'll learn a lot. Don't risk writing a poor report because you want to do something else. You're getting paid, you're on the clock. Write your report, get it done before you do anything else. Get that documentation done. It's your job. Documentation is your job. And here's the thing, if you are at your job and you've got documentation to do, but you're doing your own personal stuff, you're in the wrong. It's your responsibility.